Hi, everyone. My name is Lara, and I'm going to be moderating this symposium, track 5, which is evaluating effectiveness or quality of digital tools. I think we're still missing one presenter, but hopefully they'll just show up by the time it's their turn. We have 5 presentations in 50 minutes. So everybody will have 5 minutes for their talk and then 5 minutes for questions afterwards. If you start running over the time, I'll send you a message, but you have like 10-ish minutes total. So hopefully it'll be relatively even with the talk and the questions. So if everybody can just introduce themselves at the beginning of their talk, that would be great. And we can get started with Adrienne. And you can just share your screen and go ahead.
Hello, everyone. I'm going to share now. Are we good? Great. I am so grateful to be here to share what I think is a pretty incredible story of a global partnership to alleviate suffering during humanitarian crisis and war. I'll speak for myself in saying that my heart has been absolutely broken by the events in Ukraine. And with the help of so many people, we saw a unique opportunity here to use digital mental health as a means to make just a small contribution. So by way of context, my name is Adrienne Heinz. I'm a clinical psychologist at the VA National Center for PTSD. I'm part of the Public Digital Health Innovation Program. We have a large portfolio of federally funded mental health apps that are free, science-based, and private. No email is ever required. No data is stored or sold. And although our products are designed for veterans and with a trauma-informed lens, we like to think that there's a digital mental health safety net that's provided because anyone can use these apps anywhere in the world. I'm also pleased to have Anca Dragoi here. She is the Director of Humanitarian Assistance with Commit Global, our partner here, and is currently calling in from The Hague in the Netherlands. And you'll hear more from her in a bit.
Hi, everyone, and thank you so much for the introduction, Adrienne.
Of course, yes. So I just want to briefly say it took an absolute village, more like a city of people to make this project happen. We are fortunate to be joined by many members from the National Center for PTSD here that are on the team. Thank you for being here. Commit Global has a deep bench of talent with diverse functions. This included, also using VA legal, navigating, Washington, D.C. and bigger offices. So just want to let you know that this wasn't done lightly. It's been a big production with a lot of souls coming in to help. I'm going to turn this over now to Anca to share about the situation in Ukraine.
Thank you very much, and thank you for the opportunity to talk about a very dear partnership that we have with Veteran Affairs to make mental health services available across Central and Eastern Europe. I'll talk very briefly about the situation in Ukraine as of 2024. We're talking about millions of people affected by the war, by the ongoing military action that started in 2014, and of a more recent date, the full-scale war that started in 2022. You see the numbers. We're talking about over 14 million people that are in humanitarian need, 3.5 million internally displaced people, and 6.5 million refugees cross borders. But still, there are quite a lot of barriers in getting support when it comes to mental health services. First, the awareness, the public awareness of the PTSD remains low. There is a high level of stigma within the military, which leads to a delayed treatment. But there are also lots of barriers of a bureaucratic nature or language barriers when it comes to accessing mental services in neighboring countries that are hosting the Ukrainian refugees. Adrienne, I'll pass it to you.
Okay, I'd love for you to share about Commit Global.
Yes, that's also my turn. Yeah, we're a civic tech international NGO. We're based currently in The Hague, but we were born 8 years ago in Romania to provide digital solutions and technology for the social good. We have over 60 digital live solutions that are addressing humanitarian, civic infrastructure, and disaster relief management. These solutions vary from information systems to case managers to mobile applications, but also stock inventory, aid or shelter management. And they are at the service of civil society organizations, governments, UN agencies, and whoever else need them in case of conflicts and natural disasters. But the most important thing that we can talk about, and is the most relevant in this context and this discussion, is the fact that for the war in Ukraine, we built the first integrated and shared digital infrastructure to provide access to critical information and services for the refugees from Ukraine coming in. Over 2 million Ukrainian refugees benefited of these services, and we're currently scaling up the digital humanitarian solutions that were built in response to Ukraine in other parts and regions of the world. We're concentrating in Caucasus, Central and Latin America, and Middle East. And you can learn more about us at commitglobal.org.
Great. So it probably comes as no surprise that the prevalence of PTSD in Ukraine is skyrocketing. And we know that post-traumatic stress is a public health burden because when it's left unaddressed, the impact on individuals, children, families, and communities, it's staggering, and the suffering is profound. And so just a few updated statistics from different Ukrainian organizations and research firms showing the uptick, and especially addressing the impact on children and internationally displaced individuals. Our business is mobile apps. And so we know that mobile mental health apps, they're scalable and they can reduce a lot of the barriers that Anca mentioned, because folks can access support anywhere, any place, and do so with discretion. And this is PTSD Coach. It's our flagship app. It was launched in 2011 and actually received an award from the White House during the Obama administration for novel ways to address trauma. This was created by our center, and it has growing evidence of efficacy in reducing symptoms for PTSD. It has been internationalized for 7 countries to date. This was the first time we've done it for a humanitarian crisis of this nature. And the app itself, just briefly, has 4 main components. The first is psychoeducation. What is trauma? What would I expect if I had endured a traumatic situation? Assessment. Do I have PTSD, and how are my symptoms looking over time? Coping tools, and then resources for support. This right here is a screenshot of how the PTSD Help app appears in the App Store and also in Google Play. This is a cultural adaptation of PTSD Coach for anybody that's impacted by the war in Ukraine. So we worked with a team of translators to get the content not only translated into Ukrainian and Romanian languages, but also culturally adapted. So for example, you'll see on the home screen, there's an inspiring quote that appears every time someone uses the app. And we changed those to, cultural luminaries from Ukraine and other more culturally relevant idioms in the language and whatnot. We also had to modify recommendations based on safety. For example, there's a suicide safety planning tool in here, and we had to figure out, what do you do with lethal means restriction? What would someone do with a firearm in a war zone? How would someone dispose of medication? What are the legal differences there? And regional mental health resources and providers were identified, vetted, and then included in the app so that it was locally relevant. We've been working with our marketing team to provide consultation to Commit Global on how do you get the app to stakeholders. It's a beautiful product, but how do you get it into the hands of people that really could need it? And so Anca is going to talk a little bit more about dissemination efforts and where things are at the moment.
The application was launched at the end of November, and since then we have these numbers, which look pretty well in terms of, especially in terms of reaching out to refugees communities that are already settled in other countries than Romania, as we anticipated. So we have users from Ukraine, Romania, which is totally understandable, but also from Moldova, United Kingdom, Israel, or Germany, and the US. We have 420 downloads, 5,300 ad views. And in terms of expansion effort with the support of the marketing communication and Adrian as well, we're continuing to reaching to neighboring civil society, mental health experts and authorities. And we're currently adapting and localizing the PTSD help into Armenia in response to the Nagorno-Karabakh exodus back in September 2023. Thank you very much.
Thank you. Sorry for going over. Here's a QR code if you want to see the app. And thank you so much for your attention.
Thanks so much for the talk. We don't really have questions, where we don't have time for questions right now, but perhaps you can maybe answer them as they roll into the chat. And if we have time at the end, we can certainly get back to them. So next on the roster, we have Ansar. Please go ahead and queue up your talk and introduce yourself. Sorry, you're muted.
Sorry about that. Lovely to be here, guys. My name's Ansar. I'm presenting on behalf of my colleague, Michelle Worthington, who did a lot of this work. I'm going to be talking about assessing somebody's psychiatric functioning through analysis of speech as recorded during regular clinical interactions. The disclosures are that we all work at this company called Brooklyn Health. The point that I'm going to be trying to drive home is that for digital health measurement to really be adopted broadly, it has to be these three things. It has to be trustworthy, it has to be standardized and interoperable. By trust, I really mean not just publishing papers and sharing results, but like actually making the code open source and making it as transparent as possible. By standardization, I mean that the measure should be the same regardless of the context, whether it's academia, clinical research, or patient care. And by interoperability, I mean healthcare is a big field. Different platforms will serve different purposes, and that's how it should be. But they should all be relying on common measures across those contexts. Hopefully, when these things happen, we can drive more adoption and build trust in these measures through collective acceptance by the scientific community. With that said, let me just kind of show you what we're presenting today. So this is data from actually a clinical trial investigating a novel treatment for bipolar I depression. In clinical trials, patients will come into the clinic and be assessed by a clinician using a sort of standardized clinical scale. In this case, it was the Montgomery-Åsberg Depression Rating Scale, or the MADRS. More often than not, these clinical interviews are recorded. And the reason they're recorded is that a second clinician will listen to them and sort of rate them again in a blinded way. Where we came in is we said, hey, these recordings exist already. What if we use them for some kind of speech-based digital phenotyping and measuring patient health and functioning from their sort of like speech characteristics? The nice thing about this is that there's no app necessary, there's no additional burden that's added to the clinical interaction, like the patient clinician. For them, everything remains the same. It also allows us to do some like retrospective analyses, which is what this was. So we looked at 270 participants across several countries and really just extracted some fairly intuitive speech features that we know to be related to psychiatric functioning. So this is one of the sort of findings of relationship with depression severity. The x-axis here is the MADRS score, or depression severity. The y-axis is mean turn length. And the reason I picked this one, it's really intuitive to understand. It's like for every question that the clinician asked, how long was the answer as measured in like the number of words? And it's pretty easy to see here that as depression severity goes up, the lengths of the answers go down. This isn't really like a breakthrough finding, but the point is to show that we found this data source to be really consistent and reliable for assessing some of these sort of symptom manifestations, and they all correlated in the hypothesized direction. There's a lot of other things to show here, but I'm actually just going to focus on one other measure because what's interesting is that the pharmaceutical company was really interested in this one aspect of health and functioning of these patients, which was the level of psychomotor retardation they were exhibiting. This is something that a clinician would normally pick up on and try to quantify, but do so somewhat subjectively, where we said, what if we were able to use speech characteristics to try and quantify this objectively? And so we looked at response time, so basically the time that elapses between the question ending and the answer beginning. And so it's the difference between, hey, how are you feeling? Oh, I'm feeling okay, versus, hey, how are you feeling? I'm feeling okay. Turns out that this response time actually correlates with depression severity. It's able to distinguish people that have a lower versus higher MADRS score, although there is quite a spread in this distribution. So for those of you that haven't seen this before, this is what the result of like a $50 million clinical trials look like. The x-axis here is baseline week 1, week 2, week 4, and week 6 visits. And the y-axis is how the patients responded to treatment over time. The gray line is the placebo arm, and the green lines are the treatment arms. There's 2 different sort of like doses. And the point is to show that the people in the treatment arm responded better than the people in the placebo arm. In that case, sort of from that measure, this trial was like moderately successful, and it showed separation from placebo. But as you can see, like these are the margins that these folks are working with and showing efficacy, and it's really quite close. So when we looked only at people that had short response times, or sort of fast response times or low psychomotor retardation, the separation from placebo in these participants went away. This is actually about 1/3 of the population. But when we look only at people that at baseline showed longer response times or higher psychomotor retardation, the separation from placebo was pretty strong. In fact, the effect size of the separation doubled. This has a lot of implications for drug development and how the drug can be sort of like useful and targeted towards the right patients. But what I'm actually trying to drive home with this talk is that this kind of digital phenotyping work can be extended into other contexts, because audio and video of a clinical interaction is becoming more and more sort of like available. This is one context of a clinical trial, but like in a telehealth visit, it's not impossible to get this kind of data. There are clinicians that are starting to use automated scribing tools for clinical note taking, et cetera, where there's a microphone in the room. And all of these and many other sort of contexts present an opportunity for audio and video recording and this kind of digital phenotyping. So the question that remains is like, how do we do this part and do it in a trusted and standardized and scalable way? And to that effect, I wanted to share that basically everything that we've done here is based off of open source code. There's a Python library that we've been developing and maintaining called OpenWillis, which is basically just a bank of standard measures in digital phenotyping. And there's a lot of folks using it, and we're just trying to spread the word on this, that this exists. So if you're somebody, or particularly for an academic researcher that has access to data, visual and auditory data of patient behavior, you can just use this to like phenotype and understand speech characteristics, visual characteristics. There's other modalities in there too. But then how do we scale this in sort of commercial and clinical contexts? For that, we developed this sort of more cloud-based implementation of the same code base, which the Willis pipeline is actually like HIPAA compliant and GDPR compliant and can be globally deployed, et cetera. And organizations are using this like locally in their own server environment, so the data never has to leave where the data is right now. In scenarios where we can help with processing, we also have an API that basically allows us to ingest data, process it, and send the measures back. So all of this to say is that we're trying to build a common backend for digital phenotyping for deployment across different contexts. And we're really hoping that this sort of suite of tools allows for that to happen in a scalable way, but also does that in a way where like the methods are not proprietary or sort of like behind some kind of closed doors. My name is Anzer. I'm a neuroscientist by background. My research is in digital phenotyping. This QR code is for the listserv, not anything related to our company, but just the Python library. So if you're somebody that's interested in doing this kind of work, please just sign up for the listserv and we'll keep you updated on new measures, features, papers that come out, etc. Thank you for listening.
Well, thank you so much. It looks like we have one question in the chat. And they asked, or they said, interesting approach, should it be standardized or personalized?
That's a good question. You know, really what this is these are feature extraction tools. And you can go into a lot of different directions with it. So if you were to build some kind of like targeted precision medicine tool out of this, the first thing you have to do is extract the features. And so this would be the first step towards developing a personalized tool. But what we're trying to say is that the underlying feature extraction should be the same across the board.
Thank you. If there are additional questions, people can drop them in the chat or we can talk about them after. Alrighty, next up, we have Julia Hill. Are you here? Or anyone who's talking about patient perspectives on ethics of novel mobile technology to predict onset of neuropsychiatric disease. Alrighty, maybe they'll come later. So in that case, we'll move on to Daniel Coppersmith. Are you here?
I'm here. Can you hear me?
Yeah.
Great. All right, great.
Please take it
Yep.
away.
All right, great. I'm gonna go ahead and share my screen and go ahead and share the slides. All right. Thank you so much, everyone, for the opportunity to talk today. Just gonna go and share my slides. And okay, hopefully you should see my slides. All right. My name is Daniel Coppersmith. I am a PhD candidate in clinical psychology at Harvard University. I'll also be starting my clinical internship at the Boston VA in just a couple months. And today I'll be talking about developing and testing an automated real-time suicide risk intervention tool, which was part of my dissertation, which I defended just a few months ago. So I'll start with giving some context. So I'll be talking today about suicide research and—
Can you hear me now?
Okay.
Apparently my thing was muted, but I don't remember touching it. Just as a heads up, I have Caitlin's like session on mute next to me because she's going to be going during our call.
I think someone else is talking.
Hold on one second.
Oh, good. All right, I'm good to go. All right, I'm gonna go ahead and keep going. So there have long been kind of ethical issues in suicide research, and this is essentially pronounced in the issues of digital health and digital monitoring, and this is kind of introduced as new technologies have emerged for studying things like suicidal thoughts and behaviors, new ethical challenges. And one of those key ethical challenges is, say we're monitoring individuals with new technology such as smartphones. What do we do? What is our responsibility as researchers when individuals report perhaps having suicidal ideation or suicidal intent during the studies? And my mentor, Matthew Knock, convened kind of this statement, this Delphi panel of various experts. And a lot of people on this panel felt like researchers should do something or should respond in some way when there are reports of suicidal ideation coming in real time from participants. It's very different as we go out into the real world and collect this data as opposed to bringing individuals into a lab or in the hospital. But a systematic review led by Dr. Kate Bentley from Mass General, when kind of reviewing various protocols, identified that many research teams do not intervene, such as contacting participants immediately after they submit a response and perhaps doing safety planning. And there are various reasons. It can be logistically challenging, requires a lot of people resources, time resources, money, and then also there might be certain contexts where individuals might be anonymous and we might not be able to have their contact information. So we thought, in response to these kind of two options right now, static resources or more kind of clinician in the loop, there might be another way of approaching this really tricky kind of research and clinical problem. And some prior research led by Aaron Jaruzelski, who's also currently at Mass General, found that kind of this brief automated intervention, kind of encouraging individuals to use crisis resources such as 988, was able to lead to an increase in crisis resource use just through some brief automated messaging, kind of trying to reduce barriers and promote crisis resource use. And so we want to see if we could translate this into kind of the digital mobile health context. And so we're kind of pushing individuals to 988, and as individuals are likely aware, there's been a broader kind of national push towards this national lifeline, and there's a lot of effort and research in this, and that's kind of one of the key outcomes where we try to promote research participants to use. And so the overall project aims is we're trying to adapt our previous evidence-based barrier reduction intervention. And then we're trying to understand the feasibility and acceptability of this tool and kind of this real-time monitoring study of suicidal thoughts, or having individuals can report on smartphones several days, multiple times a day about their kind of suicidal thoughts, suicidal ideation. And the key outcomes are just engagement. So when we send kind of this resource spot that I'll talk about to people, do they open it? Do they contact crisis resources? And what feedback do they have for us as a research team? We recruit individuals through a research platform called Prolific. And we specifically sent a screener survey where we had individuals that are based in the United States, have a smartphone, and then also kind of reported having had suicidal thoughts in the past week. We had that inclusion criteria because we were trying to identify individuals who may be kind of experiencing suicidal thoughts might trigger the need for these resources in the study. The overall protocol is people were screened. Next day, they got a consent for the overall study and did a baseline assessment. They then did 2 weeks of smartphone monitoring, what's also termed commonly ecological momentary assessment. Then after 2 weeks, they did an exit survey about their experiences in the study. In the EMA period, we sent them 5 momentary surveys, 1 daily for 2 weeks during a set period. And the key item I'll be talking about there is this kind of suicidal intent, which is 0 to 10 scale. And I'll be kind of referring to this item later on, and people would fill this out multiple times a day. At the end of every one of those momentary surveys, they would see these helpful resources, which are the reminders of these resources, is that all times in our smartphone app, there was always this resource survey available where we had a list of various resources. Individuals could click on one that would provide a direct link that would take them to one of those resources. The decision rule, which is kind of from this more real-time intervention framework, is, if their intent was 0 to 1, they would just get the resource list. But if it was 2 through 10, so higher intent, then we'd show them the bot. And within this kind of resource bot, there's this overall protocol. If we confirm they meant to submit that, we offer them resources, we identify any barriers or concerns they might have about using them, and then there's psychoeducation. This bot was about 23. It follows an if-then logic. I'll give an example. And we worked with a graphic designer, Andrea, on creating images to accompany all the text that was embedded directly in the smartphone app. So the bot would say, start with this, introducing itself and confirming the intent. It would then ask if they like call or text resources. We then would show them either call or text resources, more general or more specific ones based on what they report. We then ask them how likely they are to use it, ranging from not all likely to very likely. We would then, ask them why they might not do this, and then they, based on the reason they selected, they would then get kind of a tailored psychoeducation barrier reduction message, such as the one shown here. Then they would get a reminder of where they could find these resources. We then set a follow-up survey 1 hour later. They would ask them if they did, and if yes, what resource, if not, why. So show some results from the study. We had 74 participants in the main wave. We collected several thousand momentary surveys, several hundred daily surveys. The bot was deployed 221 times to 36 participants. And the graph here shows the distribution of the number of times per those participants. So many people got 1 time, but most people actually got this bot multiple times in the study. Overall, there's an 87% engagement with the tool. So 87% of the time we sent the tool, someone opened it, and 86% of the time the person did the follow-up survey after they submitted it. The most common concerns they have about crisis lines were that wouldn't help, or that they're wanting or believing they can handle things on their own. The key outcome is, did people use crisis resources? And so 0% of the time people will report using crisis resources. But we did find that their resources were viewed 312 times across participants. And the most common reasons people said they did not use the crisis rounds is they didn't think it would help, or they handled it on their own. I'll talk more about that lack of that, which I think is really interesting. If we're viewing over time, we saw, even though individuals are not using the resources, they were kind of viewing the resources in the app and thinking about them. This is a graph of that over time. We see that the crisis text line was the most commonly viewed resource. We also asked people what other skills they were coping, and what most often people are doing are distraction and relaxation, and what they're not doing is contacting crisis lines. So there might be other coping strategies individuals are using. We overall found on 2 standardized measures of satisfaction usability, moderate acceptability, like according to some standardized scales, these would more be like kind of like a B. So they're like, okay. We also collected qualitative data. This is one example quote from a participant. That said, and the exit survey, quote, I'm pushing outside resources at me when I honestly answer I'm having a bad time. Understand you're just trying to help, but trusting when I say that I've been dealing with suicidal thoughts for this long, that I'm aware that resources exist. Perhaps highlighting the need to offer alternative resources or skills. I think this type of qualitative data from individuals with lived experience is really valuable as we think of developing ethical tools. So just some key findings, we find high engagement, so it's feasible to deploy this. We collected hundreds of surveys, we had high engagement with this tool. There's a low use of those crisis resources. I'm happy to talk more about in the Q&A and the reasons we think that. And we kind of, the more for need skill, more skills and types of resources beyond just these overall kind of national lifelines. And we find moderate acceptability and usability. I think more broadly about kind of more ways to personalize this, because this was kind of a set text, if then logic, but standardized images and tools across the study. So definitely some ways to improve upon this. So I thank my collaborators on this, including Dr. Kate Bentley from Mass General, who was very helpful, my mentor, Matthew Nock, as well as the funder of the American Psychological Foundation fund this through a grant specifically for ethics and research. And I want to thank all of you for listening. I think I'm stopping a little bit early, so leave some time for questions. So thank you so much.
Thank you. We probably have time for like one quick question right now and then maybe some more later. So what questions do folks have? Jonah.
Hi, Daniel, really great presentation. One of the things that you mentioned was that some of the results imply the fact that 0 folks actually use some of these crisis resources imply that there are some additional resources and a more diversity of resources that are needed. I'm curious what you think some of those might be.
Yeah, so just so just so you understand, I'm just going to repeat the question back to just to make sure I understand, which is essentially the question is, if individuals are not interested in using these, like the crisis text on national, what other resources might be there? Yeah, and I didn't show the quotes for sake of time, but other people were saying I want things like breathing skills or meditation or funny videos or things like, I think a lot of times with people, we sometimes think of doing a broader project with Kate Bentley on like coping strategies, looking at clusters. It seems like what people want are these more internal skills of like coping, relaxation, and maybe what's harder for individuals at times when they're feeling more suicidal is kind of reaching out for others for support. That might be too high a bar. And if we think of like the Brown-Stanley safety plan, there's a reason why there are all these different tiers of skills. And so we have some ongoing work with Kate where we're doing more micro-randomized trials. We're trying different strategies and more of those coping skills and seeing if, for some individuals, those coping skills are more helpful. So I think it's essentially the thing that I'm really interested in, just to your point, is like, say we generate like a huge list of different resources at baseline. Say we say to a person, like, here's all these videos, these different skills, these resources, what 3 would you like embed in your app during the study? And then do we see if we give people personalization at baseline and they feel like they're there's more autonomy and decision in the choice at intake, if that might then improve kind of the uptake as opposed to just the set tool that's there when you start and then you're like, this isn't really for me.
Thanks very much.
Yeah, thank you.
Thank you. It looks like you have another question in the chat, but I'll let you address that there while we move on to our next presenter, who is Caitlin. Please take it away.
Thanks, Lara. Let me share my screen. Okay, so thank you so much, everyone, for being here. I'm Caitlin Stamatis. I'm a clinical psychologist and Bruin Health's Chief Clinical Officer, and I'm super excited to share early real-world data on Bruin's tech-enabled behavioral health integration tool. So before I get started, though, a disclosure, Ariel, Andrew, and I are all Bruin employees. Okay, so to set the stage, let's talk about who is actually providing mental health care in this country. We know that 1 in 5 patients has a mental illness. Some, unfortunately, end up in the emergency department. On the other end of the spectrum, actually a minority of patients end up where we want them to end up, which is with psych specialists. But even when they do, there are challenges. So long wait times, lots of specialist shortages, especially in rural areas. So the reality is PCPs end up diagnosing and treating 80% of mental health problems. Again, lots of challenges here. PCPs are not trained to do this. They often have limited time, limited tools in their toolkit, and tend to be focused on symptoms rather than their drivers. And they also struggle to get higher acuity patients referred. So really, Bruin is asking the question, how can we innovate here where the bulk of our mental health care is happening? We're not the first to try to solve this problem. Behavioral health integration, BHI, focuses on treating mental health in primary care, but it's been really hard to implement. There are challenges with cost, with overhead, with workforce shortages. And this led us to ask the question, can we use tech to enable high quality behavioral health integration in primary care in a scalable way? So with Bruin, kind of the workflow is a PCP suspects mental health problems. They put in an order for an evaluation, just like they would a blood test or a lab from Quest. We automatically evaluate symptoms and mechanisms, and then the algorithm and knowledge base is leveraged to recommend personalized treatments to each patient. And I think this focus on mechanisms is really important because two patients with very similar symptom presentations, let's say very similar levels of depression, may get two very different sets of treatment recommendations. So for example, maybe the first has high rumination, gets referred to rumination-focused CBT, versus the second has really low positive affect, gets referred to behavioral activation. Only then do we introduce LLMs, which are leveraged to help integrate the knowledge into a PCP-friendly case conceptualization and treatment plan, which our care coordinators implement. And this is what, just quickly, one of our AI-generated provider reports looks like. So you can see their diagnostic findings, symptom mechanisms or drivers, and then this section, which is a kind of case conceptualization and treatment plan, and really is focused on actionable results for the PCP. And every decision point and recommendation is traceable. The algorithm is not a black box. Anecdotally, providers really like this. But what we wanted to explore in this study was just to start to look at some, hard data on real world use patterns from these frontline PCPs who are using our tool. So our aim is to take early real world implementation data from 225 Bruin patients in 16 physician owned, so it's kind of smaller practices, primary care practices, analyze what are their demographic characteristics, what do they look like clinically in terms of severity, and what does engagement look like with this product. So in terms of demographics in primary care, our patients are a little over half female, about 70% white, a pretty wide age range, and I think interestingly, pretty varied socioeconomic status. So about 50% of people referred have a household income below $75,000. They're also relatively high acuity. So over 60% report depression symptoms on the promise. Nearly 70% report anxiety symptoms. About half are reporting clinically significant insomnia. And about 30% say their general health is poor to fair. And here you can see adverse childhood experiences, perceived stress, generally kind of in the moderate range. And this is where the physician-owned practices using Bruin are located. And promisingly, they're pretty engaged. So you can see in this sample, or not that you can see where the practices are. And in this sample, I'll just say we have a 75% referral to completion rate among patients referred by their PCP. So again, early data, what have we learned so far? First, PCPs do seem to be using our tool with patients who really do need care based on their acuity. I think we have kind of solid geographic, gender, socioeconomic diversity, but definitely opportunities to engage more with rural areas. If you think back to that map that have kind of known psychiatric care shortages. I will say, I think one of the reasons there's high engagement by users with our tool is that it's provider initiated. There's that provider trust, provider buy-in, which is probably helped by having an answer to the question we've talked a lot about at SDMH so far, which is who pays for this, right? So PCPs can reimburse for Bruin under two codes, one for psych evaluation and one for care coordination. So it fits into their workflows in a fee-for-service model. So again, promising early findings, I think a lot of open questions, and we do want to dig more into factors that drive this, this promising engagement. So stay tuned. For now, thank you so much for your time and attention. please reach out with any questions. And I'm going to end with a truly shameless plug, which is that if this work interests you, we're hiring a clinical science PhD intern. So please reach out to me to learn more. Thank you again.
Thanks, Kate. What questions do folks have?
I have a question. You started off, first of all, thank you for that. That was wonderful. You started off with saying that there's sort of a dearth of clinicians to refer patients to, but then you said that you're taking those referrals. So like, how did you overcome the scarcity of people to diagnose and recommend a treatment plan for these patients?
Yeah, thanks. That's a great question, Enzar. So I think there are two ways that we approach that. One is thinking about, from a triaging perspective, not everyone who comes in with mental health symptoms needs a clinician, right? As part of our treatment plans, there are digital therapeutics, there are community resources, peer support groups. So I think it's being able to provide PCPs with a better sense of, for those lower acuity to moderate, severity patients, where can they go if they don't necessarily need or want therapy one-on-one? And then I think the second piece is, because we're again focused on what's actually driving these symptoms, allowing us to get at, does this person need CBT? Does this person need something else, right? We can, I think, search in a more efficient way to help connect people to resources, as opposed to like, okay, I'm searching via insurance, there are 100 options, I have no idea what's right for me. Like, our searches are a little bit more targeted because of this mechanisms-based approach.
And then, sorry, follow up. So that makes a lot of sense. I would assume these billing codes have some sort of like minimum expectations of like, you've been seen by a clinician. What is that minimum expectation? Like, where do you guys meet it? Or what do you have to do to sort of demonstrate that they can bill for this?
That's right. Yeah. So with the psych evaluation, it's 30 minutes of physician time. And so that includes both like report reviewing. So it's effectively like, we provide all of the data, they review the report, all of that counts towards the time component. And then of course they have to talk to their patient about it, right? But that, is similar to what they might do if they get blood work back. They give them a call, they talk through it and say, I'm going to put you in touch with folks who will help you take the next steps if you want to.
Got it. Thank you.
Thanks.
Any other questions? I have a question, which is, do you have data on, or I don't know, information on the PCP's, like, I guess, opinion of the AI algorithm, or like, are they explained how the report is generated? Like, how does that work?
Yeah, so in terms of we have a lot of qualitative feedback right now. I think a big next step for us, and we're seeking some research funding to do this right now, is to actually run a study where we compare, we kind of give people the outputs of our evaluations, because that's just data. We have specialists, so psychologists or psychiatrists, write up a clinical summary, and then RAI write up a clinical summary, and then have an independent group of raters compare them in terms of quality. So that's one way we've thought of trying to get at that point of like, how do we quantify the degree to which clinicians think this is of similar quality to what they'd get from a specialist report. If folks have better and smarter ideas of how to do that, I am all ears, but that's one way we're thinking about it now.
Thanks. Yeah, any other questions either for Kate or any of our other speakers? You have a couple more minutes because the one person no-showed.
I have a question in the chat. Thank you for sharing. Curious about the ownership of the recording data and any consents required from the patients. Also curious about patients' perception on the recording being accessible and used for phenotyping, model training, et cetera. All this is a great question. So, what's very important to us is that there's several layers to this. One is really just like transferring what is protected health information from where it was collected to where it will be processed. We wanted to overcome this barrier, so we essentially developed the code base so that it can be deployed locally where the recordings already live. So like our org will never actually see those recordings, we'll just license out the code. In terms of like, how do the patients feel about being recorded? In the context that we work in, which is in clinical trials, it's pretty commonplace, and patients have been like there's fairly explicit and really thorough consent processes. And that includes telling them that their, sessions will be recorded and reviewed by another clinician. How this gets translated into clinical practice, I think really happens in a distributed way, because that's now up to the clinician and the provider or the payer to basically gain that consent and ensure that they are communicating effectively. Our organization is so separated from that interaction because we're really just like a utility, that we can only recommend good practice here, but it's really ends up being up to the clinician to adequately communicate that to their patients. You're welcome.
Alrighty, well, with that, then we can adjourn the session unless anyone has any final burning questions. Thank you so much to all of our speakers. All the talks were excellent, and I hope you enjoy the rest of the conference.